let me take you through some of the named information biases that you might come across literature, and I will try to give you a few examples, and I implore you to go and read more about these biases and think through whether some of these biases could be operational in your own research work. As you see on the slide, there are several types of information biases such as misclassification bias, ecological fallacy, regression to the mean, and certain other named biases. We will see misclassification bias in a little bit more detail in the coming slides. Ecological fallacy refers to the problem when we interpret measures at the population level which may not actually be seen at the individual level. For example, if you plot the total cholesterol consumption at the country level and look at the rates of coronary artery disease in that particular population, you might see a positive correlation. That is, countries with high total cholesterol consumption have a higher rate of coronary artery disease. But this observation which you have at the population level may not be true at the individual level when you study subjects. That is, individuals who consume high cholesterol may or may not have high rates of cardiovascular or coronary heart disease. So this is what we mean by ecological fallacy. Regression to the mean refers to the phenomenon of a particular measurement, for example, blood pressure or blood sugar, regressing to the mean if you do repeated measurements. For example, say you measure the blood pressure of a hypertensive patient. The first measurement may be high, the second measurement may be high. But as you measure many more times, since the blood pressure follows a kind of distribution which is predetermined, subsequent measurements will be lower than the initial measurements. So if you take an average of all these measures, the mean will be closer to the normal. So this is what we mean by regression to the mean. When you measure several times a particular indicator or a phenomenon, they tend to regress towards the mean. And there are other information biases which we'll see in a little while. Let's go to some of the misclassification biases. So basically what misclassification bias means is that you are classifying those who are exposed as unexposed, those who are unexposed as exposed. You are classifying those who have the disease as non-diseased and those who do not have the disease as diseased. So you are misclassifying the exposure or the outcome status of the particular patient in your study. So that is the broad definition of misclassification bias. There are several ways in which misclassification bias can occur. Let us look at the first one, detection bias, under which we have a diagnostic suspicion bias. What does this mean? In clinical practice, you might have some preconceptions or you might have some prefixed idea that leads you to look for a particular disease in a particular group of people. For example, if you know the sexual orientation of a group of people, let's say homosexual men, you are more likely to suspect them of having HIV/AIDS. So you rigorously search for that particular disease or infection in them, as opposed to someone who are not having this sexual orientation. So this is called diagnostic suspicion bias. You over-check, you over-express your intention to check for a particular disease condition in a particular group of people because you have some preconceived idea about them. Observer or interviewer bias. So observer expectation bias is one of such biases where the researcher or the observer or the interviewer tries to force his expectation on a particular subject and tries to get answers which are in confirmation to that expectation. For example, if I am researcher and I want you to say that you went to a government hospital because you are poor. So I will be repeatedly probing you to say that, did you go to a government hospital? Did you go to a primary health center? It must have been expensive for you to go to a private hospital. So this sort of probing the subject or the participant to conform to an expectation which you have is called observer expectation bias. Next is apprehension bias. This is probably the most well-known or most commonly observed bias in clinical practice. This is because the participant is apprehensive about the processes or the questions that you are going to ask as a researcher. The classical example is blood pressure being raised when the patient is in the clinic, but when you measure in other circumstances, for example, in their home or when they are much more relaxed, the blood pressure tends to come down. So this bias is because the participant has some apprehension about the study or the study questions, and therefore their responses are different from normal circumstances. Then there are certain recall biases, for example, rumination bias. This we have discussed a little bit earlier as well. The person who has been affected by the disease keeps on thinking or ruminating about what went wrong, and therefore he or she is more likely to recall certain exposures which normal people do not have the need to, and therefore they do not recall. So this imbalance in how someone recollects past events because of their current condition may lead to rumination bias. Exposure suspicion bias. This happens when the investigator or the researcher has a particular preconceived idea that a particular group of people might be exposed to a certain type of exposure. For example, if the research question is about exposure to TV and childhood behavioral disorders, and if the investigator knows that a particular child is from a rich family, the researcher might try to probe in deeper about their TV exposure. Whereas if the patient or if the child is poor, from a poor background, the investigator may not probe much deeper into their exposure into television or other screen-related devices. So this is the expectation of the researcher being imposed on the participants. Participant expectation bias. This is the counterpart of observer expectation bias, where the participants try to behave in a certain way because they have some preconceived idea about the research. For example, if the researcher is well off, or the socioeconomic status between the participant and the researcher is so different that the participant tries to give answers which he or she thinks that is the appropriate answer. For example, if the investigator asks, how do you normally commute between home and work? And if the participant thinks that the appropriate answer is by using a motorcycle or by using a taxi, he will be more likely to say that answer, whereas in fact he might be going by walk or a public transport like bus or metro. So that is how the participant modifies their answering or their responses in expectation to what, in response to what they expect is supposed to be the answer. So that is participant expectation bias. Some of the other types of misclassification bias include reporting biases. For example, obsequiousness bias. This is a particularly interesting type of bias where the participant or the subjects try to give answers which satisfy the investigator. So they give responses for which they think the investigator will be happy. So if the subjects are aware of the study protocol and what it tries to aim or achieve, and if they want to gain some favor from the investigator, they would try to give some responses which are satisfactory or make the investigators happy. So you have to be very wary of this particular type of bias. Family aggregation bias is similar to the ecological fallacy that we discussed a while ago, where we make mistakes in thinking that whatever we saw at the population level also applies to the individual level. Unacceptable disease or exposure bias is a bias where you do not reveal information about a particular disease or exposure if you think that is unacceptable by the society in general. For example, drug abuse, use of smoking, use of alcohol, things like that. Underreporting bias, as the name suggests, people do not report a particular type of condition equally among the different groups. So for example, in COVID, we saw that a lot of deaths due to COVID were not reported as COVID. This might happen due to a variety of reasons, and you might have to think if there is a reason for you to worry about this particular bias in your research. Mode for mean bias refers to the tendency to give the most common value that comes across instead of the actual value. For example, if I ask your age, you would say or round it off to the nearest 5 years or nearest to 10 years instead of giving me the actual value. So that leads to sort of a mode bias instead of the actual mean. Let's look at some of the other named biases. The first one is Hawthorne effect. You might have heard about this effect where the participants change their behavior when they know that they are being observed. For example, if there is a study on how staff nurses use their time for a particular activity, and if you are observing them throughout the day on what are the different activities they are doing and how much time they spend, if they come to know that you are observing them closely, they might change their behavior in such a way that is not reflective of the usual truth. Lead time bias refers to the apparent increase in survival of a particular patient or participant just because you diagnosed the disease early. This happens in cancer survival studies where earlier diagnosis leads to an apparent increase in the survival when in fact nothing has changed. The only thing that has changed is that you have diagnosed the disease early. The patient still goes through the entire disease irrespective of the treatment and dies at the same age he would have otherwise also died. Protopathic bias, one particular example of this is the sick quitter bias, where the patients modify their behavior because of the disease. For example, let's say alcohol leads to liver cirrhosis. Everybody knows that. Once liver cirrhosis develops, the patient might be very sick and the doctor might advise him to stop using alcohol. So if you see, patients with liver cirrhosis, most of them will be non-drinkers or non-alcoholics. They might have used in the past, but if you ask them today, are you an alcoholic, they will say no. Whereas patients without liver cirrhosis who have mild or moderate disease might still be continuing to drink. So it will look as if alcohol is associated more with non-disease than with disease. So this is called the sick quitter bias. This also happens in smoking. Temporal ambiguity. This is a classical problem of the cross-sectional studies where both exposure and outcome are measured at the same time point and you don't know which has come first. Will-Rogers phenomenon is another named bias where the reclassification of a particular disease condition tends to increase the survival or tends to improve the outcomes of a particular patient. For example, you all know staging of diseases or staging of cancers changes from time to time. Classification of hypertension changes from time to time. So if you apply the newer classification standard and compare patients with the earlier or a previous standard of classification, you see an apparent improvement in the survival or the disease condition. So that is called the Will-Rogers phenomenon. It simply means that using different types of staging or different types of classification might produce an apparent improvement in the condition. Workup bias or verification bias happens in diagnostic accuracy studies where you apply the gold standard test or the reference test only to those who have a negative in the index test. So normally what happens is you test a bunch of people using the new test, which is the index test, and you test all of them with the gold standard test also. But what happens in reality is, since the gold standard test might be very expensive, you apply the gold standard test only to those who are found negative in the initial index test. So this will lead to a sort of increase in the accuracy or increase in the sensitivity of the index test, which might not actually be true. It just shows you an apparent increase. So these are some of the information biases that you might come across literature. I request you all to go back and read some of these biases and think through them and try to see whether these biases may be operational in your research. So we saw that systematic errors occur during the measurement or classification of data. When these errors occur differently in comparison groups, it causes problems. The consequences of such differential error processes can be either towards a null or away from the null. What you have to do is prevent biases wherever you can avoid by designing a proper study, thinking through what biases will occur and how to avoid them. And once you have conducted the study, and if you think that some of these biases may be operational, you have to understand and explain those biases in your discussion. Thank you very much for listening to this lecture, and I hope you have a better understanding of information biases from now on. Thank you.